Well, welcome back. In this lecture, we're going to talk about how inspiration and expiration works, or how breathing in and out works. We'll talk about kind of the atmospheric pressure, its role that it plays, and then we'll talk about some circumstances that kind of hamper this ability for normal breathing and even maxillary breathing. So first, let's talk about the atmospheric pressure, or what's related to Boyle's law. So at sea level, the atmospheric pressure is about 760 millimeters of mercury. And so if you are familiar with the Northwest, so Mount Rainier is about 14,401 feet or so, like something like that. Its atmospheric pressure is about 400 or so millimeters of mercury. Everest is over 20,000 feet. And so its atmospheric pressure is somewhere around like 250 millimeters of mercury. Okay, and we'll talk about kind of the role that the atmospheric pressure plays in kind of the lung. Well, part of this role is what we call Boyle's law. And so Boyle's law means there's an inverse relationship between pressure and volume. So as pressure goes up, volume goes down. As volume goes up, pressure goes down. Okay, so that's important to know because that's how our lungs inflate. It's related to the pressure outside of the body, the atmospheric pressure, and the pressure inside the lung, the alveolar pressure. Okay, so if the pressure inside the alveoli decreases, okay, then the atmospheric pressure is higher than the pressure inside the lung, and the air will rush in to the lungs. If the alveoli pressure increases, okay, then it can get higher than the atmospheric pressure, and the air will be pushed out or leave the lung. Okay. Now, the simple way to do this is by stimulating a very large muscle that can change the volume of the thoracic cavity. And that very large muscle is the diaphragm. Okay, so the phrenic nerve can stimulate that diaphragm to contract and move downwards, which causes the volume of the thoracic cavity to increase. If you increase the volume, the pressure goes down. If the pressure is now lower than the pressure outside the body, the air flows in. Pretty simple stuff. Okay, and we'll keep going through it and we'll just hash it out till it becomes easy to understand. Okay, so the volume thoracic cavity of the thoracic cavity would increase. Okay, that decreases the pressure from 760 to about 758. Okay, and the air would rush into the thoracic cavity. And we'll look at this as we progress. Okay, so here's just kind of a diagram of such. So when nothing's occurring, when you're just sitting there, the lungs aren't taking in air, then the atmospheric pressure outside and inside is equal. Okay, roughly 760 if you're at sea level, whatever it is wherever you're at. So if you're at the top of Mount Rainier, it's 400 outside, it's 400 inside. Okay. Everest, like 250 outside, 250 inside. So the atmospheric pressure and the lung pressure are going to equal each other if nothing's going on. Now, that's not the total reason why it becomes harder to breathe as you increase in elevation. We'll get to that in a little bit, okay? But let's say they're equal at rest, okay? Then let's say the phrenic nerve stimulates the diaphragm to flatten, to kind of move, contract, okay? That changes the volume of the thoracic cavity. When you change the volume of the thoracic cavity, you change the internal pressure, okay? when the internal pressure is changed, the air from outside, it's moving from high pressure to low pressure, it flows in, okay? Fills the cavity, okay? Fills the lung tissue, get transfer of the oxygen, transfer of CO2, etc. The diaphragm then rises back up, okay? So it relaxes back up, okay? And then that changes the volume. The pressure increases inside, more so than the outside, okay? And the flow of air is out, okay? And so, very typical way at which kind of the pressure volume is going to work. Now, there's other things that can change the pressure inside the alveoli sacs and in the bronchius tubes. There's other things that can happen that can change it versus just muscle movement. And we'll dive into some of those as we progress. So let's talk about normal inspiration or normal inhaling of air. Okay? The diaphragm, okay, is going to be stimulated. Okay? It's going to contract. The lungs will expand, or the lung cavity will, the volume of the cavity will increase and air will come in. The surfactants will reduce the surface tension in the alveoli, so that really helps relax the lung so it can expand. Okay. During maximal forces, though, now it's not a passive or a what we would say, it's not an innate or an autonomic response. The maximal force is often due to several other muscles associated with changing the thoracic cavity's volume. Okay, so things like the sternocleidoid mastoid muscle, the scalens muscle, the pectoralis minor muscle. These muscles are attached to different parts of the thoracic cavity. They can pull the ribs up, they can extend the ribs, contract, and so really just enlarging the thoracic cavity. If the premise of changing the volume is going to change the pressure, then you want a more drastic difference between the pressure inside and outside, then change the volume even more. The more you can change the volume, the greater the pressure difference is going to be. The faster, the more fill you might get from that inspiration of that air. So here's just an example of that. So you have those sternocleidoid muscles, which pulling up on the sternum, okay, which when it pulls up on the sternum, it kind of moves it out. You have the scalens that are going to elevate the ribs. You also have the pectoralis minor that's going to pull up and elevate the ribs. Okay, you have the diaphragm, which can even contract further down. Okay, all of which increase is the volume of that thoracic cavity, which causes the pressure to change. If it's increasing the pressure or increasing the volume, the pressure is going down. The difference, the greater the difference between the pressure inside and outside, the faster the air is going to move in. The more air that's going to move in, and you'll have a maximal fill. Okay. So we can look at kind of how this works, how that inspiration or how that first kind of taking in of air works. So you get the phrenic nerve that's going to fire and send a action potential down to the diaphragm. Okay, the diaphragm's a big muscle. Okay, and that contracts the diaphragm. Diaphragm then changes shape. Okay, and it, for lack of a better term, it drops. Okay, increasing the volume. Okay, and so as that dome diaphragm moves downward, the thoracic cavity expands. Okay, at the same time, you have all those intercostal muscles that are attached to the ribs, rising the ribs, spreading the ribs, increasing the thoracic cavity even further. Okay, the pressure decreases inside. Okay? The atmospheric pressure is now greater than the alveoli pressure, so the air is forced in, okay, and the lungs fill with air. Okay? Now, expiration, or getting rid of that air. Normal resting, again, this is pretty passive. This is a normal activity, passive process, okay, where now things are just returning to their normal shape. Okay, so you had it stimulated with the phrenic nerve to cause that muscle, the diaphragm, to contract. But now, as the diaphragm relaxes after stimulation, all the other muscles tend to relax, and everything tends to go back to its original shape. Okay, that changes the volume of the thoracic cavity back to its original shape, which now makes the pressure inside greater than the pressure outside, and the air is forced out. Okay. And so that normal, going back to its normal shape, is what we call elastic recoil. Okay. The surface tension can be changed, okay, by different things, like the actual surfaces can be moist. The surface tension can retract. The surfactants can um, be released or removed, and so there's quite a few things that are going on. But nonetheless, it's enough to really change the pressure by about 1 millimeter of mercury. Okay, and it's 1 millimeter of mercury higher than the atmosphere. It doesn't really matter what the atmosphere is. It could be that 760 and now you're at 761 or maybe 762. It could be that 250 on the top of Mount Everest and now you're at 251, 252. Whatever it is, it's enough to release the air from the lungs, force the air out of the lungs. Okay, again, passive process. So in regards to normal resting respiration, of course, the initial inspiration is going to result in the diaphragm movement, some of the muscles in the thoracic cavity moving. Okay, so it's not completely passive. There is energy involved there, but it's autonomic. It's, you're not thinking about it. It just happens. Okay, and then the expiration, or releasing that air, is not based on energy. No ATP is utilized to cause everything to go back to its original shape. Now, when you need to maximally force out the air, then you have contraction of other muscles, okay, abdominal muscles, intercostal muscles, and now it's no longer a passive process, but now it's an active process, and you can force the diaphragm even higher in position, okay, to push out more air out of the lungs. So it depends on both processes. Okay. All right, so let's talk a little bit about the respiratory volumes. Okay, much of this is just review from labs that we did. So we calculated using the spirometer, we calculated different volumes and capacities, and really it's related to quite a few different things. First of all, the degree of effort. So are you trying to maximize how much air is coming into the lungs, maximize how much air is leaving the lungs? Is this a tidal volume where you're just at resting and you're just looking at normal rates? And so that really determines kind of what respiratory volumes we're looking at and what they mean. So again, spirometer, that's normally what we're using. Different types. You can use big water bath ones. You can use small handheld ones. There's digital ones, all kinds of things that can calculate the tidal volume, the inspiratory and expiratory reserve volumes. So how much is left? The residual volume can't be uh, directly measured by the spirometer, but you can get at what is residual, what's left, and we'll talk a little bit about that. Sometimes that's related to, you know, like normal values. If you don't think you have a lung disorder or any history of smoking or heavy chemical use or something like that, where your lungs have been damaged, then often it's an estimate that we can use, and we'll talk about it here in a second. Okay, the vital capacity, overall, this is often, you know, compared to from a table. So you might have a table where you have this, the vital capacity, or how much air you can take in. Okay, it's related to the age, the gender, the height. Normally, it's the height of the individual. Okay, and that kind of relates. And so often these values might be compared to what the normal value is. Okay, so if you have a vital capacity and they might say, well, your vital capacity is lower, then it's possible that's because they're just pulling off based on your height and your age and your gender where your vital capacity should be, and if it's lower than that, etc. And we'll look at this again. Okay, but these are really useful tools, and were extremely useful during COVID, but they're useful to predict many different things: COPD, whether you have pneumonia, bronchial asthma, lung cancer, what's the effects of smoking, what's the effects of some job where you might be constantly exposed to smoke from some machine, or you're constantly exposed to chemicals coming off of some product that is getting into the lungs and possibly causing emphysema. So there's lots of reasons why this barometer is used, and kind of the values that will come from it. So these are just typical values for a 6-foot tall male. And so again, a lot of these would relate to age, but we'll just say it's a 20-year-old male. So you might see the tidal volume of 500, the total lung capacity near 6,000. Okay, and again, you know, these are just general values, and if you were to have these values taken, or if you're to go to do tests or whatever, okay, they would be compared based on normal values for your normal size, your normal height, your gender, your age. All right, now some of those calculations, what they're getting at, and the reason why you might look at a spirometer, maybe you're looking at tidal volume, maybe you're looking at your total ability to exhale maximum force, is maybe to get at how much of the lung or of the respiratory system is dead airspace. How much of it is not transferring oxygen? Okay, and there's two ways to look at this. There's two calculations. One, which we call anatomical dead space, and this is just related to the structures themselves. The trachea, the primary bronchi, the secondary bronchi, just the tubes themselves, areas where there's really no transfer of oxygen to begin with. It's just how much air is left in those anatomical structures after you release your air. So both inspiration and expiration, how much remains, kind of thing. So it doesn't really involve the alveoli. It doesn't involve structures that have to do with the connection to the alveoli. Then you have another dead space, and that's alveolar dead space. This is the actual air that's making it to the respiratory region, but not transferring. Okay, it's not, there's no connection, or there's poor connection with capillaries. Okay, so there's no real transfer of oxygen that's occurring in that region. And this would be really a measurement of damage that's been done to the lung. So if you have lots of, damage that's done to the lung, and maybe the alveolar sacs are dying, and so you might have open spaces where air can get captured in those open spaces but not have that direct contact with the capillaries. That would increase your alveolar dead space. Okay, together, these two together is going to make your physiological dead space. And so sometimes people want to know or will be tested to see what their physiological dead space might be. Under normal circumstances, as long as you don't have any alveolar dead space, then you would expect your anatomical dead space to equal your physiological dead space. And for most people, it's somewhere around 150 milliliters per breath. Okay, so if, though, you do have dead space, oops, sorry, well, I'll come back to that. If you do have dead space, there's another calculation, and we'll talk about that when we talk about the minute ventilation and other things related to that dead space and kind of the importance behind that. So minute ventilation, okay, is how much atmosphere, how much new atmospheric air is moved into the respiratory passage per minute. Okay, so easy to calculate. Tidal volume. Okay, so at rest, how much air are you taking in and expelling? Okay. Then what's your respiration rate? So how many breaths per minute are you breathing? Okay, so you times those two together, and that gives you the volume of air that is being ventilated. Now, that's assuming there's really no dead space. That's assuming that the dead space is normal at about 150 milliliters per minute. And so if, though, however, you think that your physiological dead space might differ from normal, then more often we're interested in the alveolar ventilation rate, or the AVR. Now it's the same kind of equation, except for now we're taking in the dead space, and we're interested in how much dead space is affecting this. So now you're looking at that tidal volume, okay, minus the dead space, and then you multiply it by the breathing rate. Okay, so this dead space can increase, and it can increase with damage to the alveolar sacs. So if you're damaging it and you're increasing the amount of dead space, so you're over that 150 milliliters, then you're probably, you're going to have a change in AVR. Right? And this becomes important when we look at things that might affect an individual, like maybe an individual that has cystic fibrosis. And so you could look at their AVR when they're really young, and then as they're aging, so we can find out, is there damage to the alveolar sacs? Do they have a lot of physiological dead space? Okay, and that can give you an idea of kind of, how that disease might be progressing. Okay. There's some other things, non-respiratory air movement. Generally, like, these are just things that can cause air to move out of the body, like coughing, sneezing, laughing, crying. Hiccuping is kind of an interesting one. I think it's debatable on what its function is. Some hypotheses that have quite a bit of kind of at least generalized evidence suggests that this is a vestigial characteristic. This is a characteristic that's carried on from ancestors of ours, ancestors that once had gills, because the hiccuping, or that spasmic process, it it looks like the spasms that we see in gills, and so that's possibly the reason why we see kind of hiccups occur, that it's just this vestigial characteristic that's carried on. We never got rid of it. It's annoying. It's not lethal, but that's probably the case. Yawning, there's also a few hypotheses about what's the function. I think right now the one that's probably got the most evidence is that yawning is related to being able to take a deep breath, and it starts very young in an organism's life, and that yawning is associated with that contraction, that deep contraction of the diaphragm. So it's really stretching those muscles. It's training those muscles to be able to take a deep breath. And the evidence points to, young individuals like babies and things like that. They yawn a lot, and that process of yawning is really kind of practice on taking deep breaths. May or may not be true, but currently I think that's the most evidence is suggested there. Okay, and then of course speech. And we talked about this when we talk about the larynx. Okay, a lot of this is just air being forced out through the glottis, and then the vocal cords, vibration, etc., the tongue, soft palate, and the role that they play. All right, clinical applications. There's quite a few things that can alter your ability to have ventilation, from either decrease it or change it in some way by making you breathe faster, increase your respiratory rate, etc. One that is on the rise, it's been on the rise, I don't know, for a very long time, partly because we're better at documenting it, but partly because we probably pollute a lot more. And so asthma is an inflammation that occurs in the bronchial tract. It's normally related to foreign material, either organic like pollen or dander or something like that, but it also can be related to chemicals. And so you can have bronchial asthma that's related to lots of different things. So some people are allergic to things like mold. And so you might have a allergic response to those mold granules, or typically spores being taken in through an inhalation. Okay, they get trapped in the cilia, in the mucus, and then your immune system reacts to it because the antigens that occur on that mold, on that fungus, causes that reaction, and then you get inflammation. You get fluid flowing into that region, inflammation, okay, and that constricts the bronchial tubes. Okay. Other things, though, could be related to a chemical. That you're reacting to the chemical. The chemical causes the irritant, and you get constriction of the tubes. So we do see a increased rate of bronchial asthma in urban environments, most likely due to air pollution. But again, normally it's somewhat treatable, in the sense that often a bronchial dilator is used to alleviate that constriction. Okay, so the smooth muscles are relaxed, and that opens back up the air passageway and allows air to move through. Okay, so very typical. I think about 25% now, or somewhere in that range, of individuals that are born today will develop asthma in their lifetime. So it's fairly high rates of asthma. Emphysema is more a long-term damage situation, and this can be due to lots of different causes. Emphysema in itself is just kind of a label that we typically stick on conditions where the alveolar wall has been destroyed. Okay, so it can be due to a few different things. Normally we see this due to things like chemical ingestion like cigarettes, vaping, that kind of stuff. But it's degenerative disease that destroys the alveolar wall. Okay? And then instead of having lots of alveolar sacs, you tend to just get large alveoli with open spaces, and that increases the dead space, right? And so it decreases the ability for gas exchange. Surface area increases, and the capillary action or the transferability is diminished. Okay. We call it a type of COPD or chronic obstructive pulmonary disease. Okay. And so again, there's lots of things that are labeled COPD, and it just depends on the individual, like what is causing the damage on what we narrow it down to, emphysema, etc. And so here you can kind of see what I was talking about with the expansion or the uh, alveoli sacs being larger. So over here is normal. Okay, so you have these alveoli sacs, single-celled, wrapped around it, capillary beds associated with them. Okay, good transferability of oxygen, carbon dioxide, and then you have the emphysema over here, where you have large, expansive areas where the tissue is open. It's died, it's dead. Like a lot of those epithelial cells have deteriorated and died, and now you just have these big open spaces. Well, that has a decrease in surface area, and so the air that's in these open spaces are less likely to transfer into any capillary beds that are nearby, and so you have less transferability and poor ability to transfer oxygen into the blood and carbon dioxide out. Okay, next time we'll talk about some other issues dealing with pressure, volume, altitude sickness, etc.